Hello, good afternoon to all of you. My name is Sarun Chan. I am recently joined as a project coordinator in this Trivandrum Institute of Palliative Science in this ECHO program. And welcome all of you to this PalliCovid ECHO program session 2. And today we have sessions on managing symptoms complex of agitation and breathlessness in context of COVID-19. The sessions will carry out by Dr. SUNITHA Daniel. Welcome, ma'am, and hand over to Sunil sir for the facilitation of this session. Hello, Sunil sir.
Thank you, Arun.
Okay, sir.
So, good afternoon. Today we have a very important session. We know that there are many physical suffering in COVID-19. And one of the main problem with the COVID-19 patients is having agitation and breathlessness. So we will hear from Dr. SUNITHA Daniel how to manage the symptom complex of agitation and breathlessness. Dr. SUNITHA has done her MRCP in general medicine and MRCP in palliative medicine. She has been working in UK. And at present, she is working in General Hospital, Ernakulam, as a specialist palliative care physician. She is also a member of PalliCovid Kerala. Welcome, Dr. Sunitha, and it's over to you.
Thank you, Sunil. Am I audible?
Yes, you are audible.
And thanks to Palli Media for giving me another opportunity. Is my slides visible?
Yeah, but it's can you put it in presentation mode?
Is that better?
Hello, Sunitha ma'am.
Hello.
Ma'am, can you share the slide, please? Yes, ma'am. It's fine.
Okay. So good afternoon, everyone. We'll start the session today. And today I'll be dealing with the symptom management aspect of the major two symptoms that a patient who has COVID-19 can present with, and where the palliative care has a role to provide some support. The learning objectives for this half-an-hour session would be to learn how to assess and rate the severity of breathlessness in patients with COVID-19. Also to identify agitation with and without delirium, again, patients with COVID-19. And how do we learn how to manage both symptoms? Familiarize with the use of algorithms. So those of you who have attended the session from the introductory session yesterday must be familiar with the ebook that has been developed as a resource along with these presentations, and you must have received the link to download the ebook yesterday. So all these algorithms that we have discussed make you familiarize with how to use the algorithm to manage both the symptoms. So those of you who haven't downloaded the ebook, please do so now. So you'll be able to understand the session better. And also another useful app that you can use is a PalliCare app, which was developed from by Karunashraya from Bangalore, and they have got some wonderful guidelines for normal symptom management for palliative care settings. So how do the patients with COVID-19 usually present? And all the data that we have got is from the clinical studies that has been published from China and Italy. So most commonly, how they present is most of them present with the least serious presentation. This is a subclinical case where they have the virus but they don't have any symptoms. And then few of them present with upper respiratory tract symptoms, infection like fever, cough with milder symptoms like headache and conjunctivitis. And these people, again, are able to transmit the virus. Some can even present as flu-like symptoms, and this will keep people off work, and or if they can also present themselves to the hospital to be tested. And then finally, the thing that we usually worry about is a severe illness, which can present with the complex of breathlessness and agitation. So those with relatively severe illness will have the more complex symptom pathology of breathlessness and agitation. And our presentation today is just to deal with those patients. And according to the papers published from the early published work from China, 80% of patients will have mild illness, 14% will have severe illness, and 5% will have critical illness, usually requiring ventilatory support. Now, once they develop the critical illness or develop this referred to as COVID-19 pneumonia, they usually have the cardinal symptoms of high breathlessness or air hunger, where they're struggling to breathe and struggling to get air, which will be accompanied by a high distress. So these patients usually, their end of life symptoms are usually with high breathlessness, high distress, progressing on to high delirium or agitation, and high fever. And the sad thing to know is that all these can happen pretty quickly. So there will be a risk of cessation of life, which can happen over a short number of hours and maybe short days. So we don't have much time to deal with them. We really have got one chance to get it right, and we should make sure that our approach is that they are symptom-free and comfortable during the last hours of life. As I mentioned, these are some percentages of the common symptoms. So you can see that there are lots of other symptoms, but these are the ones that commonly there. Fever, we all know, 77 to 98% of patients do have fever. Cough, usually a dry cough, 57 to 82%. Dyspnea, which we're dealing with in today's presentation, 18 to 57%. Then other symptoms are myalgia, fatigue, and we have also, have case reports of ENT physicians reporting altered sense of taste and altered sense of smell, and the numbers are quite high also, so 44% and 53%. These are the common symptoms where patients can present with COVID-19. Now let's look at a bit of a pathophysiology of the presentation. So the pathophysiology can be divided into 3 stages, and stage 1, stage 2, and stage 3. The stage 1 is referred to as early infection, where, as I mentioned, they can have mild clinical symptoms and signs like fever, dry cough, headache, diarrhea, and the clinical signs of the lab investigations show lymphopenia, increased prothrombin time, increased D-dimer, and LDH. Now, some patients will just present with stage 1 and then they get better. And at that stage is where they have got the increased viral response phase. Some patients, unfortunately, will progress on to stage 2 or the pulmonary disease, which is divided into stage 2A and 2B, where the patients can present with dyspnea and hypoxia. And they can have signs showing abnormal chest X-ray, abnormal blood investigation like transaminitis, and low normal procalcitonin. And then further on, some patients can then unfortunately move on to stage 3, which is the more critical stage, where there's a hyperinflation stage, and they can present with acute respiratory distress syndrome or ARDS, and systemic inflammatory response syndrome or SIRS. Also, death can occur because of cardiac failure. The lab investigation shows a raised inflammatory markers like CRP and LDH, elevated troponin, pro-BNP. Now, the stage 2 and the stage 3 are together called as a host inflammatory response phase. And if you look at the slide, the one that is given in yellow is the potential therapies that has been tried at different places. Sometimes as a part of research, or sometimes as just clinical, as just an empirical therapy. And like remdesivir, chloroquine, hydroxychloroquine, convalescent plasma transfusion. And the one that is only one that has shown some sort of a positive suggestion is remdesivir from reports from US. And the most important point for us to remember for this session and as palliative care in the point of view is that the cytokine storm that is usually described, which happens towards the 2nd and the 3rd stage, causes a hyperinflammation and then can present as the severe breathlessness agitation complex. So what is different in palliative care for COVID-19 patient and why is it important? Now, according to a blog that was published in the British Medical Journal, Opinion, the doctors were looking after patients in a small town in Italy. They have redefined the role of palliative care in such patients. They describe how they are faced with an ultra emergency situation where there is no relationship between the patient and the family and the physician or the healthcare worker. There is no typical palliation timing for sharing and planning the treatment path. And the deaths are linked to the traumatic psychological experience for the family and the members of the treating team. So situation can change rapidly, that the typical palliative care physician doesn't get the time or the chance to have the direct face-to-face conversation with patients and the family. So all the blogs that's been written about the patients and the physicians or the healthcare providers, it tells about the speed with which the things are changing, where we don't have enough time to, the patient or the family doesn't have enough time to come to terms with the situation. The physicians themselves don't have the time to actually accept the fact that patient is dying, because things change pretty quickly. So the time for the conversations, everything is pretty shortened. Now coming on to the first symptom of breathlessness. Now, at this moment, I would like to pause, and then I would like you to reflect about the last breathless patient that you saw in clinical practice. It could be any of the COVID-19 patients, if you have seen them in your clinical practice, or it could be patients with any other cause of breathlessness, and that you have found it difficult to manage. To me personally, this is it's a difficult symptom to manage than any of the other palliative care symptoms. And I think the most important reason is that this is it's more than a vital sign to all human beings. It's one of those signs that is intensely connected to your own living. So we all know that when we start the life and end your life, it's often described in terms of the first and the last breath a person takes. And sometimes, we all know that we breathe every day, day in and day out, but we are not aware of the fact that we are breathing. It's just part of our life. And sometimes patients are known to describe breathlessness as, I have been breathing all my life, but now I have started experiencing it. So it's an unpleasant sensation, the sensation of not able to catch your breath, the sensation of air hunger, and the resulting panic that accompanies it. I have heard lots of patients tell to me, my worst worry is, will I be dying, or will I die without able to catch my breath, without getting any air? And that's a very, very frightening feeling. And that is what we deal with here in these patients. So and what is so special about the breathlessness in particular to COVID-19 patient? So I already described the complex pathophysiology that's involved, including the cytokine storm and the hyperinflammatory stage. And also there's been lots of explanations about what exactly happens in the lung. So it can be pneumonic consolidation, alveolar damage, pleural effusion, and some new theories like microthrombi formation. So everybody knows that it's a complex pathophysiology. And that's one of the main factors why breathlessness is complex in COVID-19. In addition, there are other factors like the vulnerability, like when age advances and with all the other comorbidities, it's proven that the disease trajectory becomes worse. The patient, on the other hand, is loaded with a lot of information from general media, from social media, newspaper. There's no, and lots of information loading. And also there's an additional anxiety that till now there is no specific treatment for COVID-19. This will worsen the anxiety of the patients. And then on top of that, the patients will be managed in the isolation ward. That will add on to the anxiety. And breathlessness and not able to catch breath is quite intensely linked with anxiety. So there are other reasons for the anxiety of the patients to get worse. And then on top of that, there'll be other psychosocial reasons like the association of guilt, fear, the loss of income, because most of the patients, as we all know, we're all in lockdown now. So there's this decrease in income in all the professional class of life. And once you get the infection, that's add on to that, you already have got a loss of income. So all these can contribute to the psychosocial aspect of the symptom. So it's not just from the cardiac or the pulmonary point of view, but it's a complex symptom that's intensely connected to a patient. So coming to the management of breathlessness. Now, all the management guidelines that we present throughout our ECHO module is similar to the guidelines that is mentioned in the ebook, which has been adapted from the NICE guidelines and the Association of Palliative Medicine guidelines, which is published online, and a recent publication from the European Respiratory Journal. And all these guidelines assume that the patient is receiving all the appropriate supportive treatment and the correctable causes of the symptoms has been considered and managed. So the target population that we mentioned in this guideline are those who already have are following the COVID-19 management protocol. All the correctable factors, so antibiotics should be treated with antibiotics for superadded infection to improve the fever and cough. All the other management for bronchodilators, for breathlessness, other management has been corrected, and also to optimize any other comorbidities. So patients who've already got COPD or heart failure, but all their medications has been already rationalized and used. And treat the bronchospasm if present, correct the correctable factors. And once all these has been taken care of and the patient still breathless, that is when we use a term called refractory breathlessness, where breathlessness is not improving despite the optimal medical management. And those patients are the ones that we are using for these guidelines. So the management in the ebook and in this presentation has been divided into two. When I come to the algorithm, it will be more clear for you. The patients are managed in the ward and in the ICU, and all the patients are managed with non-pharmacological measures and pharmacological measures. When we first come to non-pharmacological measures, there are various non-pharmacological measures techniques that is available that can be used for breathlessness management.
Hello, ma'am. Sunitha, ma'am.
Hello.
Yeah. Ma'am, your voice is breaking.
Okay. My power supply has gone off, but I think the connection is still working. Okay. Am I audible now?
Yes, ma'am. Yes, ma'am.
Okay. In case my internet goes, then there will be a delay before I can rejoin. Okay. I'm just letting you know. Okay. Yeah. Okay. Can I continue?
Yes, ma'am.
Okay. So the various non-pharmacological techniques that can be used for breathlessness: relaxed tummy breathing, breathe rectangle, recovery breathing, calming hand technique. I'm not going to details here, but the idea is to try, if possible, try and train the patients in some sort of breathing techniques, which again, with the use of PPE, how much we're able to achieve in such patients is questionable. But if the patients are not unwell, it's worthwhile teaching them some non-pharmacological measures. Now, positioning is very, very important. Appropriate positioning, or the position which gives the maximum comfort, should be followed, and various advice depending on the position, like sit upright, legs uncrossed, let the shoulders droop, or keep the head up and lean forward. The other one is, other important thing that is coming out now is, nursing the patients in a prone position can improve the ventilation, and even before the mechanical ventilation stage, if you nurse the patients in prone position, they are seen to do better. Now, some relaxation techniques can be taught by the respiratory physiotherapist, and some of this may not be applicable in the acute crisis, but you can properly teach the patients when the symptom is slowly progressing. You can train them in relaxation breathing techniques. Now, one of the important techniques that simple technique that you can teach the patient is pursed lip breathing, where you describe it as the action of smelling a flower and blowing a candle, where expiration should take twice the time of inspiration. Now, other non-pharmacological measures are cooling the room, reducing the room temperature, cooling the face using a cool flannel or cloth. I'm not sure whether you are familiar with the use of using handheld fan for breathlessness, which is one of the proven and evidence-based methods of non-pharmacological management in palliative care for breathlessness. But in the current scenario, we are advising against the use of handheld fan because there's risk of spread of infection. Oxygen inhalation is also very important, and it should be given to patients to relieve breathlessness, and those patients who are hypoxic and where invasive ventilation is not indicated. Moving on to the pharmacological management. Again, this has been divided into management in the ward and management in ward.
Hello, ma'am.
Hello, sorry. Okay, sorry about that. So the pharmacological management, is the slides clear now?
Yes, ma'am. Yes, ma'am.
Yes, yes.
Okay, so the pharmacological management that's been suggested is with the use of morphine. So we have divided that into mild to moderate breathlessness and severe breathlessness, and we have divided that again into ward management and ICU management. So we can use morphine and midazolam, particularly with anxiety without disorientation. The doses that we have suggested is a starting dose for mild to moderate breathlessness. We start with oral morphine, 2.5 to 5 milligram per orally, Q4th hourly, or you can also give 1 to 2 milligram subcut. If the patient has got, in addition to that, anxiety because of breathlessness, you can also give a benzodiazepine like midazolam, 2 to 5 milligram, Q4th hourly, slow IV or subcut. Or you can also try lorazepam, 0.5 to 1 milligram sublingually as and when needed for agitation and anxiety. The symptoms doesn't settle with the bolus doses, and if you've got the opportunity, or if you've got the facility to start a continuous infusion, you can start continuous infusion of morphine 10 milligram and midazolam 10 milligram IV or subcut over 24 hours. In case the patient is elderly or if the renal function is abnormal, you can start at a lower dose of morphine, or you can start at 6-hourly interval. And as I mentioned, midazolam can be given. It's very short acting, and lorazepam, unlike midazolam, has got a longer duration of action. Now, I'm not sure how many of you are familiar with the use of morphine for breathlessness, but I'll just describe, or I'll just explain to you a bit more detail why we are doing that. And we all know that morphine has always been a highly feared drug, but now we've got sufficient evidence to say that morphine can be used to manage breathlessness. Can be used to manage breathlessness, as morphine reduces the hyperventilatory response to hypercapnia, so that the respiratory rate comes down, and as a result of that, the work of breathing comes down. The second way is that it produces pulmonary vasodilatation, which results in a better ventilation perfusion ratio. Then we all know that morphine is used for myocardial infarction, for chest pain, for pulmonary edema, along with diuretics. So morphine has got a vasodilatory property, which reduces the cardiac work and helps in the cardiac output. In addition, morphine also causes the sedation of the cortical centers. And since breathlessness is a feeling, the feeling of breathlessness is reduced. Now, this was seen in a randomized crossover trial, where a single dose of administration of immediate release morphine to patients with chronic breathlessness syndrome, so advanced COPD patients, and those with chronic breathlessness syndrome showed a meaningful improvement in the exertional breathlessness and the exercise endurance. Now, this is found to be because of awareness of the respiratory drive, the reduced awareness in the respiratory drive, because the signals to the various cortical and subcortical centers was impaired with the use of the morphine, and all these centers will have opioid receptors. So in addition to all that, morphine also produces an effective analgesia. So the patient has got any pain along with breathlessness. The analgesia produced by morphine, the morphine works on the analgesia, and therefore the patient will be able to breathe comfortably. Now coming to management, continuing with the management the ICU. The difference between the management in the ward and the management of the ICU is that maybe parenteral administration of drug will be more preferred in ICU setting. So we have given dosage of morphine, just IV or subcut dosage. So morphine, the same dose, 1.5 to 2.5 mg, IV or subcut Q too early. Or we're also given a dose of fentanyl, where some ICUs prefer using fentanyl, or they're more comfortable using fentanyl. So we can give fentanyl 25 microgram IV or subcut Q2 hourly. The dosage of midazolam and lorazepam are the same as in the ward. Now, fentanyl is also a better choice if patients with chronic kidney disease, because toxic metabolites can accumulate if morphine is used. So if fentanyl is not available, then you can use morphine, but reduce dose and increase in the duration. But if fentanyl is available, it's always better to use fentanyl in CKD patients. So again, as I said, continuous infusion is better, mainly because the symptom might be very, very difficult to control. Boluses would be, be shorter acting, won't be lasting enough. So if you're able to give a start dose and start an infusion, then it's well and good. So you can start an infusion morphine 15 milligram, or fentanyl 100 microgram, and midazolam 10 to 30 milligram, IV or subcut over 24 hours. The dosages that we have suggested is just the suggestion or starting dosages. The doses could be changed according to the patient requirements. So decreased or increased according to the patient condition. And other thing to remember is both these drugs can be given together. So morphine and midazolam can be combined together in a single syringe driver and administered. Now, significant breathlessness towards the end of life. The patient is clearly dying with breathlessness. All the active treatment, in spite of all the active treatment for COVID-19, the patient is still clearly dying, and the respiratory rate probably more than 30 per minute. The dosage is slightly different. We go with a higher dosage, so morphine 2.5 milligram or 5 milligram IV or subcut. 2.5 milligram IV, 5 milligram subcut, or fentanyl 25 microgram IV or 50 microgram subcut as a starting dose. Midazolam 2.5 milligrams low IV, 5 mg subcut. This can be repeated every 15 to 30 minutes till the situation or condition improves. Or you can give a bolus dose and then start a continuous infusion morphine 30 milligram or fentanyl 150 to 300 microgram and midazolam 15 to 60 milligram IV or subcut over 24 hours. Again, the dosage is given to act as a guide to the physicians. And as I mentioned before, we don't have much time to make them comfortable. We have got one chance to get it right. So if you go with lower doses, we might not be able to make them comfortable on time. That's the reason we've given this dosage. Again, you can call if palliative care is available in the setting where you're working. Please contact them for further advice. This is the algorithm which is given in the ebook, and it's currently in the current version. It's given the page 14, but will soon be uploading the second version of the ebook. So the pages might be different in that. So everything that I've mentioned, the slides, is in this algorithm. Basically, refractory breathlessness is divided into patient ICU and patient ward, and they are managed as non-pharmacological and pharmacological methods. And significant distress towards end of life, the management remains the same, and that's in the last box. So to summarize, morphine is a useful drug in relieving breathlessness and providing cough breathlessness and providing added symptom relief and quality of life. Judiciously administered morphine did not produce respiratory depression. Morphine can be administered by multiple routes, including per-orally, IV, subcut, and PR. Consultation with a palliative care specialist can be complementing to ensure the symptom relief. Moving on to the second symptom of delirium and agitation. Here again, imagine a patient that you've seen last who's confused, agitated. The picture here is actually taken of a patient who has got delirium tremens or alcohol withdrawal. But any particular patient like that who doesn't know where he is, who's confused, is trying to get out. Now, what we see in COVID-19 is typically that they become breathless, they become hypoxic, and they go into a situation of delirium or agitation. So a typical clinical scenario would be a patient with symptoms of COVID-19 who was managing at home but became more breathless and had to be admitted to hospital, who's very, very anxious. But as soon as he comes to the hospital, he'll be examined by the healthcare team, but obviously would be isolated from the beginning. He has mild fever at home, has been quarantined, and once he becomes positive, he'll get admitted. At that point, there will be mild anxiety because of all the things that is happening around him. And he'll be examined with the healthcare team in a busy admission area. They'll mild anxiety. It could be because of the fact that he's away from the family, or worries about what is there in store for him with regards to his diagnosis and management, and then there'll be the accompanying dyspnea. And then when the dyspnea worsens and patient becomes hypoxic, he becomes anxious and restless. That is the first stage, but he's still oriented. Now, this is one point where we can interfere and help the patient. And then later on, the patient continues to become anxious and restless and becomes more hypoxic and then becomes disoriented and continues to be agitated and disoriented. So in this clinical scenario, there are two places where we can intervene and manage. And our algorithm is divided on these two, where the patient is agitated and restless, but oriented and disoriented. Now, how do you assess a patient? Again, you must have learned with delirium, there are lots of tools that can be used to assess patients with delirium, which is obviously very, very time consuming. And so one of the simplest tool that probably that we can use in this scenario is something called as the 480 delirium assessment tool, which which actually goes through the 4 A's, which are: one is alertness, AMT4, which is abbreviated mental test score 4, attention, and acute change of fluctuating course. So how do you how do you try to find out whether the patient is alert or not? So the patient is normal or fully alert and not agitated, they get a score of 0. If they're mild sleepiness for less than 10 seconds, but then if you wake the patient up, they're normal, again, they only score 0. But if the alertness is clearly abnormal, they are very, very drowsy and not able to wake them up, then they get a score of 4. That's how you score alertness. Second one is AMT4, where you ask the patient about the age. There are 4 simple questions: age, date of birth, name of the hospital they are in, and which is the current year. If they answer without any mistake, they don't have any score, or they score 0. If there's 1 mistake, they score 1. And if there are 2 or more mistakes or they're untestable, they score 2. Third one is attention. We ask your patients to list the month of the year backwards. And if they're able to list at least 7 months or more correctly, they don't score anything. If they start to list the months backwards, but they only score less than 7 months, or they refuse to start, they score 1. Again, they are untestable. They cannot start because they're clearly unwell or drowsy. They score 2. And the last one is about the acute change of fluctuating course, which is where there is evidence of significant change or fluctuation in the alertness or cognition or other mental function, which is arising over the last 2 weeks, but is still evident in the last 24 hours. Now, this might be untestable or difficult to detect in our patients because usually the patient might come on their own because of the quarantine issues. So we can only detect this by phoning the family back home. So that is the last one. And if they score 4 or more according to this scale, there's a possible delirium. And that's the clinical scale to assess delirium. And so again, depending on the scenario, whether we are able to do this for all our patients, again, depends on the clinical situation. But this is the simplest tool that's available. Now, how do you, if the patient presents with anxiety and agitation, delirium, there are some other things that we might have to consider in addition. So we have spoken about breathlessness and hypoxia, and that can cause a delirium. That's a major thing in COVID-19. But there are other situations that can make the patient delirious, and these also need to be assessed before we start the proper management of delirium. So it could be pain. So the COVID-19 can present with myalgia, or some patients are already on the pain medications for maybe cancer pain or any other chronic pain situation, which can get worsened, and the medications have not been administered to the patient, so the pain is worsened, and that can cause them to become delirious. They can also have withdrawal syndrome. So they could be withdrawing from alcohol or other drugs which they have been normally taking, and that can be the reason of the delirium. Or the other causes, simple causes like urinary retention or constipation. So again, appropriate to the clinical condition. If you think that they are delirious not just because of COVID-19 agitation, but there are some correctable factors going on, make sure that you look for the correctable factors and correct them before we start the management of delirium as such. And again, as I mentioned before, the management of delirium mentioned the ebook has been taken from the NICE guidelines as well as Center to Advanced Palliative Care guidelines. And all these guidelines also mention about checking for other cause of delirium before we start the management. So this management is also divided into non-pharmacological aspects and pharmacological management. Non-pharmacological would be slightly more difficult in this scenario because again, there is no direct patient-to-patient, face-to-face contact in our COVID-19 situation. But the healthcare professionals are advised to be calm as far as possible, responsive, optimal response to the patients. Whenever the patient asks a question or they are concerned, try and address their concerns as much as possible, not causing them undue panic, and not causing undue panic in ourselves also. We should be calm and compassionate as much as possible. Always start a gentle conversation. Try and reassure the patient. Again, keep the room air and lighted as much as possible. And some of the reason why the patient, one of the reason the patient could be confused or concerned is because they would want to convey a message to the family. So proactively ask for such questions. Encourage them to ask for any questions that they might have, any concerns or the worries that they might have, so that their anxiety is allayed. Coming to the pharmacological management, again, we have divided that into the two groups. The agitated and oriented patient who is anxious, who's got anxiety and panic and fear, but they are oriented. So the benzodiazepines are the first line medications we have suggested in that. The patient is able to solo, start with a lorazepam, 0.5 to 1 milligram twice daily orally. Or you can also use clonazepam, 0.25 to milligram to 0.5 milligram twice daily. If the patient is not able to solo, we can try midazolam 2.5 to 5 milligram bolus injection, which can also be given as needed injection SOS. Now, if the patient is agitated and oriented, but the agitation becomes moderate or the agitation persists, then as I mentioned in breathlessness, we can start, or if you can start a continuous infusion of IV or subcut of midazolam, can be started with 10 milligram over 24 hours. And symptoms still persist after starting infusion, we can add in a antipsychotic like haloperidol. So you can give 0.5 milligram every 15 minutes as needed, or 1.5 to 5 milligram as an infusion over 24 hours. Now, our next group of patient who is agitated but is disoriented or proper delirium. Here we suggest a first-line medication of haloperidol instead of the benzodiazepine. So start with haloperidol, 1 milligram, slow IV or subcut, or 1.5 milligram per orally. This dose can be repeated every hour up to a dose of 5 milligram. Or a bolus injection of 1 milligram haloperidol can be given IV or subcut, and you start a continuous infusion of 5 milligram haloperidol at the same time. And as I mentioned before, if you have a facility to start a continuous infusion, start it alongside we give the bolus dose, because that will provide a background medication to settle the patient better. Sorry. Now, if the delirium persists and becomes moderate, you can add injection midazolam 1 milligram, slow IV or subcut, and repeat every 10 minutes till the patient becomes settled. Or you can give a bolus injection of 2 milligram midazolam, given IV or subcut, and a continuous infusion of midazolam can be started along with haloperidol. So as I mentioned in breathlessness slide, again, we can give two medications together. Midazolam and haloperidol can be given together. Even 3 medications can be given together in a single syringe driver. So the patient who has a symptom complex of breathlessness and agitation can have a infusion with morphine, midazolam, and haloperidol in the particular doses. Intractable agitation delirium with the symptoms persisting, maximum dose of the haloperidol 20 milligram and midazolam 30 milligram can be given as a continuous infusion. Now, this is a maximum suggested dose, which all the patients might not be needed, but again, we have suggested that as a guidance. And if they've got 3 symptoms, 3 drugs can be given together. This is the algorithm which covers the agitation, and we have divided that into, as I mentioned, with delirium and without delirium. This is given in page 19 of the current version of the ebook. So to summarize, we need to recognize that there's a symptom complex of breathlessness and agitation together in a severe COVID-19 pneumonia. For delirium, 480 tool is an assessment tool, is quick to use tool. And remember to assess and rule out and manage other causes of delirium. For anxiety and restlessness without disorientation, start a benzodiazepine. For restlessness, agitation with disorientation, start an antipsychotic. We've also given you with some further resources and training. All these websites are useful links for COVID-19 as well as details about palliative care in case you're interested. And this, yeah. So thank you very much. And please give your valuable feedback at the end of the session, which will help us to improve our future sessions. Thank you.
Thank you, Sunitha. So the session is open for discussion. If anybody has any comments or questions, please come up now.
Hello, Pranab sir.
Yeah. Am I audible?
Yes, yes, sir. You're audible.
Thank you, Dr. Sunitha, for your brilliant, mind-blowing presentation. But one query is there, that COVID-19 patient, especially the elderly one, who feels that he will be completely lonely, and this loneliness may surge his anxiety, his tension, and if I'm not wrong, this will increase his breathlessness, isn't it? Breathlessness,
That's right,
and
sir.
agitation.
Yeah, the anxiety itself can, worsen his breathlessness and cause him to have panic attacks.
Yeah. Actually,
yeah.
This time, so far we know that the COVID-19 patient really feels that he will be going alone. He will be dying alone. Nobody will touch. Nobody, even no family members, no close nearest and dearest ones will come closer to him. So this feeling, this mental distress of feeling that he will be going alone, I think this will increase breathlessness and agitation.
Yes, the psychosocial symptoms in COVID-19 patients as such is a separate session, and it's very, very important. And to manage them, actually we need to address anxiety first. You're right, rather than going on to manage the breathlessness. And once that anxiety is taken care of, we probably wouldn't even have to manage the breathlessness. So you're quite right, sir. Thank you for that comment.
Okay, thank you, madam.
Yes, Manveer. Can you unmute yourself?
Sorry.
Dr. Manveer? Yeah.
Am I audible? Yeah. Thank you for the session, ma'am. I had 2 questions. One is like we have difficulty procuring morphine. So like will midas alone help in a case of refractory breathlessness? One. And the second one is like you said, for cooling of the face, we cannot really use handheld fans or even table fans. So what other techniques can we employ for the non-pharmacological methods, which are more possible given our situation?
So I'll answer the easier one first. The cooling of the face, probably we can use cold cloth or flannel, or cold wipes can be used, which can be applied on the face. The room itself can be kept cold. So that's how we could do that. Regarding the morphine availability, you don't even have IV morphine in your institution, am I right? Or?
No, we don't, like, the sister doesn't indent morphine.
So what about the ICUs? Do they use fentanyl?
Fentanyl we can procure.
Okay, so probably fentanyl might be the other option, even though the trials that has been done for the breathlessness is mostly for morphine and oxycodone. We have given the dosage of fentanyl because some institute might only have fentanyl, so you could try that. Midazolam is a sedative. We usually add it as a second line once the morphine is given and the patient doesn't settle and has got anxiety or panic attack. That's when we go for midazolam. But if the patient is really not settled and you can't get hold of an opioid, then you don't have any other option but to give midazolam. But try fentanyl first, and if the patient is in the ward, also try and use fentanyl and manage them if possible.
Thank you.
Anybody else? Any comments? Geeta madam, do you have any comments?
Crisp and clear presentation. It was so good to listen to Sunitha.
Thanks, ma'am. All the others, like I don't think we have got much participants, so can you just say in chat? Otherwise, have you all used morphine before for breathlessness? Those who are not doing palliative care, the non-palliative care people, and what's your experience? Things like that. Anybody can comment. Either unmute yourself, or you can comment in the chat box. Are you familiar with the use of morphine?
I don't see any chat or questions. Sunitha, there is no chat questions or comments.
Okay, Sunil, that's fine.
Are there anybody raising their hands?
No, sir.
Okay.
Sir.
Yeah. So I think, shall we wind up the session, Sunitha?
Okay, yeah, we'll just get the feedback and then wind up the session.
Yeah. So Dr. Sunitha was talking about breathlessness and agitation, which might usually occur together in COVID-19. Patient can have breathlessness, which can lead to anxiety and which can again lead to agitation and sometimes to disorientation. So the management of breathlessness is with mainly with opioids, low doses of morphine, or if not available, fentanyl can be used. And if the patient is having agitation, agitation with and patient is oriented, then midazolam alone can be used. But if the patient is not oriented, then antipsychotics should be used first. And if the patient has breathlessness and agitation with disorientation, then probably all three medications, haloperidol, uh, morphine, and midazolam, has to be given as a continuous infusion. So uh, thank you, Sunitha, for this wonderful session, and thank you all for attending and asking your comments, making it interactive. So before you leave, I request you to kindly do this feedback questions, which will help us to improve. I hope all of you can see the questions on your screen.
I kindly request all of you to attend this poll before you leave, because your feedback is extremely important to us. It's a request.